right, everybody present, please be advised, we're going to record this work group meeting. So anything said verbally or in the chat may become part of the recording. All right, Dr. Rice.
Okay. Well, hello. It looks like it is just me and Heather and Shelly today. So thank you for joining. This will obviously probably go pretty quickly then. So I think, Heather, I think you've done these before with us. So I'm just going to Shelly's going to kind of go through slide by slide. And I'm going to pull up on my other screen. MS edits. Yeah, there it is. Okay. And that way, oops. Move this over to the other screen. Having screen issues. Okay. Okay, now I can see what Shelly's presenting, and then I've got Matt. So I'm going to kind of follow along with you, Shelly.
Okay.
So some of this was Matt's, and then I added some slides, and then it looks like Matt made some comments on the slides. So this will be good.
Heather, if you have anything to add, please hop in there.
Oh yeah, for sure.
So this one obviously is the STR for EMTs. So keeping that in mind, this should be mostly EMT level information. So looking at the objectives, indications and contraindications. We'll see if we need to add anything to that. I think there's like some troubleshooting section, or I would put in the objectives a third bullet for something about confirming placement. So understanding or explain, how do I say this? Explain how to confirm placement, or ensure information.
Ensuring confirmation of placement.
Yeah, something like that, because we want that to be an objective. And then I feel like there's some stuff in here about, we've got indications, contraindications, and then maybe before that, Shelly, put describe iGel insertion procedure. Okay, and that's probably good for objectives.
I'm going to put the little acronym SGA on this page.
Perfect.
All right. Next slide.
Okay. So let's see. Let me go back up, see if Matt had anything here.
I think he added the iPubmed info.
Okay.
Or PubMed info, sorry.
Supraglottic area devices. Okay. And then the next slide is the photo that just talked about anatomy. Hi, Glenn. How are you?
I'm good. Can you guys hear me?
Yeah, we can hear you.
Okay, good. Sorry.
No worries. We've just gone through the objectives slide. And we're just kind of going slide by slide.
Okay.
So here's the anatomy slide. And then let's see. You can go to the next one, Shelly.
All right.
Difficult placement. He doesn't have any notes on this one.
Next one.
Indications for placement. Yeah, that looks good.
All right, moving on.
So if they have a gag reflex, they can't open their mouth. Known esophageal diseases. Maybe we want to change SAD to SGA, Shelly.
Oh, right.
Contraindicated esophageal cause air burns. And I think we could probably get rid of the last sentence because we already put that in a contraindication. Yeah. That's probably good. Okay. All right.
Next one.
Yep. So preparation, position, prepare monitoring equipment, select appropriate size. Okay.
Next.
Let's see. Oh, yeah, he had SGA. Oh, back up to the other slide that says indications. He had a note to say they in the last line. Change that to SGA. SGAs can be used. Yeah, just to make it clear.
All right.
And then he's got preparation. And then on the slide that says technique, he has,
There's several slides that have this header. Am I in the right one?
yeah. So he was saying on the front, oh, dip the eye gel into the tray to lubricate the back sides. And I think front, I mean, I would say instead of front, say tip of the cuff. Because I think what he's saying, the front being the part that goes on the cords, but I think what we're trying to say is the tip of it that goes in the mouth. Remove excess lubricant. Okay.
Next.
Okay. This one looks
Next.
good. Introduce the leading soft tip of the device into the mouth in the direction toward the hard palate. So he has, with continuous and gentle push, and then until definitive resistance is felt on that last line. So just add at the very end of that sentence.
All right.
Until definitive resistance is felt. Okay. Oh, and then I think that this slide might be duplicated.
This next one.
Yeah.
Okay. I'm going to delete this one.
Or at least delete those last two bullets can go up a slide. I think they probably, yeah. And then delete this slide. Let me know if any of this doesn't make sense as we're reading through this. Taped maxilla. Okay.
And next.
Oh, channel is spelled wrong, obviously. And then that is supposed to be integrated byte block.
With a D. Integrated. That's in it with a D. T to a D. Or is that T? Oh,
think
it's
T.
spelled correct. That's right.
Yeah. Sometimes it looks weird though.
Yeah.
So he has presenter notes on the next slide, I think that he's added.
This one.
Yeah. Which is fine. So he's just describing it as, and then Matt has added some presenter notes to the next slide. So we have the sizes.
Does this slide have what he was wanting?
Mm-hmm.
Okay.
Yeah.
Moving to 15, slide 15.
So, mhm. Oh, these are just presenter notes. They were already there.
Okay.
So the question for you guys is now, do we say earlier in the slide in terms of the setup and getting ready for it, we say to select the appropriate size. Should this slide be up there where we say select appropriate size and then put this slide? Because
I
we
think
kind
that
of,
makes the most sense. It's Heather Amber. I think it makes the most sense if you go through, you talk about placement, where it goes, and then you talk about the size, and then it gives you the size, and then you go into the preparation and how you.
Yeah.
It makes
yeah.
the chronological order make more sense.
Yeah, so maybe move this slide, Shelley, to after preparation.
Okay.
Right? I think that's what it was. Yeah,
Just
right
that-
there.
Like as you describe, like pick the right size, and then you start to talk about how this is a weight-based tool, not height-based. And so,
Right.
okay.
Right.
All right.
I think have 1, 2, 3, 4 slides of technique.
Mm-hmm.
Should we be replacing iGel with SGA?
Well, so we don't talk about any other SGAs in here. When we had done our first meeting, we had discussed
The LMAs, right?
the other ones, but it
Yeah.
sounded like nobody's using King Airways or anything else. So we had decided not to spend a bunch of time on those. If they wanted to, they could add those slides in, but we felt like we would just focus on the
I'm just
iPad.
gonna slide a registered trademark on one of the early slides for it then.
Yeah.
Okay. After the technique slides, we have ideal placement.
Yeah. The cuff should be located against the laryngeal framework. Yeah.
We have this picture one.
So go up one more, Shelley. The epiglot, no, down one, sorry, ideal placement. The
Okay.
tip should be located into the upper esophageal airway. What's the upper esophageal airway? What does that mean? I don't know if that's like the best way to describe that. I'm going to go to their website really quick and see how they describe it. The cuff should be located against the laryngeal framework. The epiglottis should be located on the epiglottic rest. Again, that doesn't make sense to me. Okay, the tip of the device should be located into the upper esophageal opening. Yeah, that makes more sense to me, and not airway. And the cuff should be located against the laryngeal framework. The incisor should be resting on the integrated bite block. I would get rid of that epiglottis line because that doesn't make any sense. I don't know. What do you guys think? I don't know what that means exactly. I don't know where that came from.
Do we have consensus?
Because you wouldn't
Yeah,
know.
no, that makes a lot more sense. I
Yeah.
agree.
I mean, I know what they're saying.
I was looking at the website too. Sorry.
Yeah, no, I know what they're saying with the epiglottic rest of the, I just think
Right.
that that's like way beyond, they can't see the epiglottis, so you'd never
Right.
know it was resting on the epiglottic rest.
Right.
And so I think it would just be confusing to EMTs to put that in there. So I think that's enough. Okay. My gel design. And again, I don't know if we should move these up.
Before ideal placement.
Yeah, because I don't know why we talk about like how to play, like what we place it, and then we're like, okay, this is what they look like. I just feel like this
Okay.
slide and one after it, we should move up maybe to the beginning where we talk about what an iGel is. So like up to, oh, I don't know. Let's see.
Below slide 3, supraglottic airway devices.
Yeah, maybe.
We do have an anatomy slide there, but maybe have the one with the iGel below it.
Yeah, that's a good idea. I don't mind it there. That's fine.
Right. Just move it up to match it.
Yeah. Those are, and then are there two, Shelley, that are, oh no, it's just that one. Oh no, there's
This,
two.
yeah,
iGel,
I think I'll.
and then there's another iGel design one that can go up there.
Okay.
Okay. Yeah, some of this is just like rearranging. Indications. Okay, so now we've talked about how to place it. So now we're talking about indications and contraindications. We already did this, didn't we?
Yeah, indications for placement in slide 8 now.
Okay. All right, and then if you go down, do we have it again? Yeah, so maybe we need to delete those.
Okay.
Yeah, both of those. Indications, contraindications, and then insertion procedure also is duplicated. Yeah.
Okay.
I think we were just like copying and pasting stuff. And we didn't edit it enough before we sent it out. Insertion procedure. So we already went through ideal placement. Now we have a slide that has a picture of the insertion procedure. Let's see, are any of these? So we got rid of those. So the last slide is ideal placement that we have there. Technique. Yes, I guess then we can just follow it with the photos of the insertion procedures. Yeah, I think that's probably fine.
Okay. The next one has a picture of the
Do
printing.
not apply excessive force. It is not necessary to insert fingers or thumbs. If there's early resistance during insertion, a jaw thrust insertion with deep rotation is recommended. Yeah, perfect.
And then the next picture one.
Yeah. Okay. And then, but we don't talk about, where do we talk about measuring end tidal CO2 to confirm placement? Do we have that on there? We only have it.
It's on what is now slide 15.
Oh, I
confirm
think
placement
confirm
with
placement
end
of CO2 form. I feel like we should put. I feel like we should put that again. What do you guys think? Should we put like another, like a whole slide that says confirm placement, or it's a really important point, but.
Yeah, I think we could add, after insertion towards the bottom, before we even maybe get to the important points, put
Okay.
the confirmation of placement.
Yeah.
and then the use of end-tidal CO2. And should we even put like what a normal range is, Amber, you think? Like
Yeah, we could do
35
that. We,
45?
yeah, we can
I mean, it's
say,
newer. We teach that when we actually teach this, our EMTs up here. They've been doing it a while, to be honest with you.
yeah,
But that's something we talk about, and it's not something they do regularly. I mean, they are now that's within their scope, but it's a new thing.
right. So I think we can put, like in the first line, Shelley, you can put end tidal CO2 is required, or is the gold standard for confirmation of SGA placement. And then you can get rid of the next line. And then we can put normal ranges, and we could put 3 different bullets on there. We can say, I mean, because the problem is most of the time this is in cardiac arrest, so they're never going to see normal ranges. Because 90% of the time they're using these or more,
Right.
they're in cardiac arrest.
Okay.
You could say something like on that bullet, maybe instead of normal ranges, say, you know, you should see a waveform. I'm trying to think of a way to say this. You should be able to see a waveform on the end tidal. On the end tidal monitor or whatever, yeah. And then another bullet that says, so the next bullet would be if using in cardiac arrest, end tidal CO2 values will be lower than normal. And then we can put the normal range. Normal range for end tidal CO2 is 35 to 45. Millimeters of mercury.
HG.
Mm-hmm.
Yeah.
Big H, yeah. Little G, yeah, perfect.
Perfect.
Yeah.
Can't you guys just change it? It's like instead of that first sentence saying end tidal CO2. So technically it's not really end tidal CO2 that's the gold standard. It's waveform capnography. So if you guys just change end tidal CO2 to waveform capnography,
Sure.
that's the gold standard.
Yeah, I agree with you.
Yeah. No, that's good.
Yeah. Yep. Gold standard for yeah, perfect. You should be able to see a waveform on the monitor if using cardiac. I don't know. Is this EMT level enough? I feel like it is.
Yeah, I think it is.
Glenn, is there anything else you would add
Uh,
that we glossed over or didn't cover well enough?
my only other question is like, what if, so this is for EMTs, right? So if we were to train EMTs on this, like we don't, when I worked for the fire department, we were going through all of this when we went to the iGel. We didn't require the waveform capnography. What we knew was the confirmation of placement was, you know, bilateral breath sounds, equal rise and fall of chest. So for waveform capnography to be golden standard, it's always ALS, because we're the only ones that carry a monitor, right?
Yeah.
An EMT's not going to carry a monitor. They're not going to carry a capnograph. They're not going to carry a what's the stuff that we use at the hospital? The capnometer, like the little cube capnometers. They don't really use that. So
they're definitely required that now, though. I mean,
but how are they going to have a monitor?
I'd be surprised.
Crew.
All of our agencies carry monitors. Even the BLS crews would use.
Yeah. That same up here.
Yeah, we wouldn't allow them to put in an airway that they couldn't confirm.
Okay.
So I wouldn't, you know, at least in my agencies, I wouldn't allow them to have it if they couldn't confirm it.
Okay.
And so, and now that the waveform capnography is also an STR, they should be able to receive training in both.
Okay. Then maybe after this slide, we put what a waveform capnography is supposed to look like.
Yeah, we can. Yeah, we can
Yeah.
put a slide with that in it. We could pull it from we did the Entitled CO2 training already, right, Shelley?
Yeah, just a recap.
Yeah.
I'm sure we could probably pull a slide from that one just
Yeah.
to show what the waveform should look like.
Right.
Let me see if it's on there. Oh, I bet I have it in my box here.
And then if that's the case, that should have your range on there, correct? For your training, it should tell you should have a waveform capnography, and then it should normally those pictures say 35 to 45 is your range.
Yeah, but like I said, most of the time these are in cardiac arrest patients. Like there's never a time an EMT would put this in I wouldn't say never. It'd be very unlikely an EMT would put this in not in a cardiac arrest. Oh yeah, here it is. Here's our capnography one. See if I can.
Do you want to tell me what slide number in which presentation you have?
Yeah, so I think it would be slide number 17, 18. I don't know if you have the same one as me.
On
I have what's on my thing.
and the training is STR for not CPAP. It's that other one.
Entitled, yeah. Capnography. I don't know. Did we finish that one, Shelley?
It's up.
Okay. I have it as like slides, maybe one that's on my computer from the last time we worked on it. Slides like 17. I don't have a good picture of like cardiac arrest, do I? Oh yeah, I do.
Am I displaying the one you have?
Oh yeah, Shelley.
All right.
Go down one maybe. Like this slide, just to show what the waveform is. Yeah. That was just a review. Yeah, that's probably fine. What else?
Confirm placement.
Yeah. Waveform capnography is gold standard for confirmation. You should be able to wait for on the antenna monitor if used in cardiac arrest and tells you lower than normal. Yeah.
A picture.
Yeah. And then important points. Unable to ventilate. I would say if unable to ventilate or confirm placement. Remove device and replace. I would put, does that make sense? The water soluble lubricant part. If water soluble lubricant is used, do not apply near ventilatory openings. Or should we just say do not put lubricant near ventilatory openings?
I think either way would be good. I
Okay,
mean, if you want to make it simple and clear, you could say just not to do it near ventilatory, like you said,
okay.
but
And again, it says do not allow peak airway pressures to exceed 40. Will they know what that means?
I don't think they're going to know what that means.
I would, unless we just say, it basically saying that you can't ventilate aggressively, that you're,
Right.
Is
Do
there
not
any bags that-
hyperventilate, maybe?
Is
Could we
there
do
any
that
bags that
instead?
have that? Like
no,
I
they
know the
don't.
smart bags for
Exactly.
pediatrics has a
Exactly.
40 centimeter of water pop-off valve on it. And
Exactly.
then the adult bags don't have that unless you have a manometer on there specifically.
Yeah, exactly. So I think we should find a way to phrase this that says like, that is,
Maybe, is there a way to put like don't hyperventilate or don't,
well,
but I mean, but then if you're trying, yeah, that's not the right word.
yeah. You could probably just clarify this. Do not allow peak airway pressure to exceed 40 centimeters of water.
Don't squeeze the bag too hard. I don't know.
Exactly. Ventilate with gentle pressure
Yeah.
to avoid. I guess what you're trying to avoid is, I would just
Barrel
put
trauma.
pressure. Yeah.
You're just avoiding barrel trauma.
Well, you're trying to keep from inflating the esophagus. So if you ventilate, if you put more than 40 centimeters of water in, that air is not going to go into the lungs. It's going to go into the belly. I would just say gastric inflation, Shelley.
Okay.
Gastric inflation. Yeah. Yeah. Yeah, we don't want it to go into the belly. Okay. Let me pull up one other thing that I have with. I have another slide that I thought might be good for here.
Okay.
Where is it? Teaching presentations. It's here. I have a slide on. Okay. Like a troubleshooting slide. I have one troubleshooting slide that basically says, make sure the head is in the correct position, make sure it is not backed out. Yeah, maybe we add one more slide, Shelley. Sorry, my Zoom phone rings to every single device that I own. You have another slide?
Let's call it troubleshooting.
Yeah. And then let me just copy and paste into the chat the text that I have on this slide. That might be easier for you.
Okay.
What do you think?
Yeah, let's do it.
Paste. Okay. And then I think, Shelley, maybe we'll need to go through and just make sure that the way we have iGel written is the same.
Yeah, I'll do a global edit for
Okay.
IGL.
Perfect. I think that's the only one. And then our references slide. We need a little TLC. I don't know.
I might need to split it up into 2 slides or
Yeah, it's not a bad idea. Half and half.
yeah.
All right, Glenn and Heather, anything else you think we've missed?
I looked up gastric distension. This is just what we know in RT school. It's not 40 centimeters of water. It takes 25 centimeters of water to open up the esophagus. So I found another slide that these guys wrote, like it's a checkoff for supraglottic airway,
Mhm.
and then what it is. Squeeze the bag over 1 second, just enough to see chest rise. Avoid high airway pressures, 25 centimeters of water, and gastric distension. So maybe reverbish that, because 40 is a lot.
40 is
right?
a lot. Yeah.
So it doesn't take much at all to open the esophagus whatsoever.
Yeah, it's usually 20.
It's 25, I believe. That's what we know in RT world is 25.
Yeah. So go back up to slide, that one more. Oh, no, wait. User tips? I think it's on the user tips slide. Sorry, Shelley.
That's okay.
Yeah. You could say 25.
Yeah.
Changing
verbiage
40 to
was-
25.
Squeeze the bag over 1 second to provide just enough air to see chest rise. Avoid high airway pressures, 25 centimeters of water, and gastric distension.
Is that a better word? Distension? Or should I use both words?
Here, say that again. Glenn, read that one more time.
It says, squeeze the bag over 1 second, providing just enough air to see chest rise. Avoid high airway pressure, 25 centimeters of water, and gastric distension. You can put gastric inflation. It's the same, synonymous.
So this would be the first bullet now, Shelley. Or like before the beginning of this bullet would say this part. Squeeze the bag over 1 second, just enough to see chest rise.
And you want the squeeze the bag to be first.
Wait, no. Go back,
Undo.
right? I don't think we need to move it.
Oh.
I just would say that bullet should just say squeeze the bag Is it
Over 1
over
second.
1 second, just to see chest rise. Just, yeah. And then the second part says what, Glenn?
Second part says, avoid high airway pressure.
Yeah, so maybe like, or delete the beginning part of that. Shelley, and say avoid high airway pressures over 25 centimeters of water. Yeah. Pressure. And gastric distension. And then so, yeah. And just delete that whole last sentence.
Yeah.
And then after centimeters of water, say and gastric distension.
Yeah.
Yeah. Yeah, I like that better. Thank you, Glenn. Perfect. Okay. Cool. I like it.
Can I see the troubleshooting slide one more time?
Sure. Oops, sorry.
Anything in there confusing, Glenn?
No, it looks good so far. Just looking at the way it's the language.
Yeah, we can reword any of this.
Okay.
That sounds funky.
And there's another opportunity for edits at the meeting as well.
Yeah.
True.
What happens when this is just insertion. This has nothing to do with ROSC. Let's say hypothetically speaking, we get ROSC.
Mm-hmm.
EMTs on scene and the medics aren't there yet.
Mm-hmm.
How do we address that here or another time?
In terms of how so?
Let's say hypothetically speaking, you got EMTs witness cardiac arrest. You're doing a standby, start
Right.
CPR, get
Mhm.
your aid on this guy right away, put this thing in. You
Mhm.
get ROSC. The guy starts resuming. He starts regaining consciousness. What do we do then? So remember what it says. I think somewhere in there we talked about if it doesn't inflate the lungs. One of these slides said then maybe remove it. What do we want to address that, or we don't need to address that because that's probably a different topic like ROSC.
I don't think so, because I think it's one of those things where, I mean, I guess it theoretically could happen that before the medics get there, they would feel the need to remove it because the person is waking up and gagging on it. But
Right.
I don't know. Do you guys think we need to address that here? I mean, this is more about insertion,
Yeah. More about insertion.
but I don't know. Do you think that comes up a lot?
No. Doesn't
No.
come up at all.
I was just thinking, yeah, I don't think it would.
It's come up for me, but usually by that time I'm not really, we're not thinking airway. I've had several ROS, but I've only had an OPA and
Yeah.
not just
Mhm.
haven't had an
Yeah,
iGel
I
in
think-
place.
I mean, we
Yeah,
could,
and I think the other thing is if you get ROSC and they're starting to gag, it's pretty
Yeah.
visual.
yeah.
Yeah. And then one
I
more
would
thing is,
hope that they would take.
Yeah,
do you guys put filters on these, like a HEPA filter?
we do. But
That on the slide.
Yeah.
you could put that on there. You could say on your insertion part, like up at the top where we say, maybe go up a few more. That last insertion slide, Shelley.
Maybe after do you guys do it after confirming the placement, or do you guys do it while you're placing it?
I don't think it really matters. We do it like all at once, but
Yeah.
I don't know that that's necessary. Go up one more, Shelley. Attach BVM to 15 millimeter connector. Secure. And then like at the end say, oh, maybe say attach BVM to 15 millimeter connector with waveform capnography and viral filter. And then maybe in parentheses, if available. I think everyone has them now, but that was a good point.
And you got to put them before. Do you guys put them before, or you guys put them after the filter? Because if
They
you put them
should
before,
be,
if you put the filter before the end title, that prevents them from getting clogged.
yeah. So ideally your end title is as close to the person as possible. So we usually put bag, filter, end title. So the end title is closest to the patient.
Oh, okay. Because I work with a guy from Guad, he teaches for me, and I was showing him how I do, like when I'm doing event transport, how I do how we put it on, because we always have to have a filter because the LTV, if you don't put it close to the patient, the exhaust port's gonna, like, there's just an exhaust port there, and what that does is it lets whatever virus or whatever bacteria is gonna come out right there out of that exhaust port.
Yeah.
So normally we do a 2 filter. So I was talking to him about it, and then we were talking about supraglottic airways, and he says the way they do it is supraglottic airway, HEPA, end tidal.
Yeah,
bag
that's how
valve
we do it.
mask.
That's how we do it.
Okay.
But actually, I don't know that it matters that much.
Because I was asking them, like, when they do that, does your end tidal get clogged if you get closer to the patient? You know, sometimes the end tidal, because we were talking about like the difference between, like, if you work at county hospital, they don't do ABGs. They do they have end tidal. It's an inline, but we have a water cup, and the water cup you have to drain because the condensation will screw up. Not that these transport times are really long like this, but that's what we were just talking about. And so he was like, no, we do it like this all the time to prevent that condensation inside the capnography or the ETCO2.
Right.
And then I know I teach with another guy when we do event training at AMR. He has a mnemonic. How does he do it? It's called SHIT.
Mm-hmm.
That's what he calls it.
Mm-hmm.
I forget what the S is for, but I know it's HEPA, inline, and then the ventilator, transport ventilator. That's what I forgot what the S stands for, but that's what he calls it. And
Yeah.
I go, okay.
This article, it says, order of connection is a good rule of thumb. Keep end tidal connectors close to the advanced airway as possible.
Mm-hmm.
Hindering sampling airflow with tube extensions, HEPA filters, and other adapters can cause a decrease in sampling size. So keep your adapter connection as close to the patient as possible. So we typically keep but I don't know that I think people do it differently.
Right.
I don't know. I've seen some people do the HEPA after and some before because they think that it clogs, but I mean, you should be able to use your inline without any kind of filter. Technically.
Right.
I mean, we didn't used to use them at all.
Well, COVID changed that game because the guy, I work with the guy that used to do he was the Philips, not the Philips, so he was the Life Pack 15 rep.
Mhm.
And one day we were talking about it, and he goes, oh yeah, so when you put this capno line in and you screw it in there,
Mhm.
this sampling port in there. So it's kind of like my hazmat.
Mhm.
There's a sampling port,
Mhm.
but the exhaust port is where the batteries are.
Mhm. Right.
No filter there. So like if you're the person and this thing is sampling and it's sampling COVID would technically be coming out right here. And I was like, well, that's a great idea.
Whoops.
So with that said,
Yeah.
if it's sampling and you're not filtering it before that line, then it's coming out the back of your whatever monitor you're using. There's going to be an exhaust port there.
Yeah.
I don't know if that makes any sense.
Yeah, it does.
So I can ask my guy again, because like I said, we weren't putting capno lines on these whatsoever when I was working for Phoenix Fire.
Mhm.
And so we would just go automatically. We would have the filter on there,
Mhm.
and then you can put the oxygen.
Mhm.
Like on 200 chest compressions, we connect the oxygen to it and just let the oxygen free flow, or we can choose to bag them after specific rounds of CPR, or we get a tube in place.
Right.
But I just don't recall. So I'll ask my quad guy, because that's how they pretty much run all their codes now, is they use the supraglottic airway. They rarely ever tube. So I'll ask him how he has it, and then maybe when we do this next meeting, I'll just ask him.
If there's anything that
I'll
needs to
email you guys. Yeah, the way they do it.
Yeah, sounds good.
Okay.
Okay, Shelley, I think we're good.
Everybody, we have consensus. We're all good.
It's good. Thank
Oh, it
you.
looks good. Yeah,
Yeah.
thank you.
Thank you guys for your help today. I appreciate it.
Sorry I was late, and sorry. I really want to make them as much as possible.
No
I just got
problem.
busy.
Nope, I know how it goes. Okay,
Mhm.
Shelley, let me know if you need anything else.
Okay, I think we have our draft ready for the meeting.
Cool. Thank you, Shelley.
Thank
Thank
you.
you.
Thanks, guys.
Okay,
Bye.
take care.
Bye.